my patient, a 61-year-old male, Mr. XYZ, who works as a farmer, mainly agricultural, paddy and wheat, since the past 40 years, residing at Chitradurga, hailing from Karnataka. He came with the chief complaints of breathlessness in 6 months and cough with expectorations in 6 months. Coming to the history of presenting illness, the breathlessness was insidious in onset, gradually progressive, initially from grade 1 Modified Medical Research Council to grade 3, initially increased on lying on the left and relieves on lying on the right side. There was initial wheeze that was there for about 1 to 2 months, and following that, the wheeze subsequently reduced on its own. There is no history of any associated paroxysmal nocturnal dyspnea or orthopnea that the patient noticed.
Hello, can you go to the first slide, Balaji?
Yes, sir.
Yeah, after this, next slide. See, breathlessness in 6 months,
Yes,
cough with expectoration 6 months, isn't it?
Yes, sir.
What is the age of the patient?
61-year-old male, sir.
Okay. So, only these two complaints.
Yes, sir.
What are the possibilities if somebody has got a breathlessness 6 months, cough with expectoration of 6 months duration?
Yes, sir.
What disorders do you consider?
Sir, with this background, one would be either it could be a cardiac cause or a respiratory cause in the system wise, sir.
Do you think cardiac cause will present with significant cough with sputum? May not be.
Predominantly, it will be respiratory here because there is cough with expectoration.
Yes. So, can you tell some disorders?
Yes, sir.
6 months breathlessness, cough, sputum.
Yes, sir. One could be
more likely to be a respiratory disorder.
Yes, sir.
Yeah.
One could be the chronic obstructive pulmonary disease. One could be the COPD that is commonly that we see.
See, COPD definition wise, no? What is the definition of chronic bronchitis?
At least cough with predominant expectoration for minimum.
The definition.
For a period of 2 years, it should be there.
See, there should be cough sputum of most of the days for minimum of 3 months in 2 consecutive years. So it is not satisfying that, isn't it?
Yes, sir.
As per the whatever data given.
Yes, sir.
So tell some other disorders: cough, sputum, dyspnea, 6 months. Respiratory predominantly.
One could be commonly tuberculosis can be presenting. With
possible. Why breathlessness in tuberculosis?
If it is a endobronchial with extensive involvement of the bronchus, then there can be associated breathlessness.
So
or if it is
significant pulmonary parenchyma involved, yes, they can have breathlessness. Any other reason? Breathlessness in tuberculosis, pulmonary tuberculosis, of course.
If there is a coexisting pleural effusion,
significant pleural effusion, yes. Any other reason? If there is a significant damage to the lung parenchyma, yes, either it is a pulmonary or pleural fibrosis, no, later on, then they can have breathlessness. So it is still possible that it may be a form of pulmonary tuberculosis. Any other disorder? Mention 2, 3 at least. Cough, sputum, breathlessness, 6 months. Respiratory.
One could be could be an interstitial lung disease.
They do not usually present with a lot of cough and sputum.
Yes, sir. Expectoration
predominantly breathlessness, isn't it?
Yeah. Yes, sir. I was thinking ILD with the secondary bronchiectasis that can present.
Less likely.
Yes, sir.
Is it possible that it may be something like delayed resolving pneumonia or a fungal infection?
Yes, sir.
Isn't it?
Yes, sir. Possible, sir.
Some network issues are there, it seems. We will wait for a few seconds.
That may present like this. Okay, proceed. Next slide.
Yes, sir.
Next slide, you put it, sir. Okay. Insidious, gradually progressive. What do you mean by that? Grade 1 to 3 MMRC?
Sir, initially the patient noticed it initially while climbing a flight of stairs.
Okay.
After he got breathless after climbing about 1 to 2 flight of stairs.
Okay.
But, since these past 6 months, he's having breathlessness even on walking on a level ground. For about few meters, if he walks, he feels breathless, sir.
Okay, you have written there. It is written.
Yes, sir.
It is predominantly lying on the left side, relieves on lying on the right side.
Yes, sir.
What is the interpretation of that, do you think?
So this like technically it's called as strepopnea. So possibility
Okay.
of either a effusion on the left side could be possible, sir.
No, it may not suggest effusion. It looks like it is suggesting a significant disease on the which side? See, left side lying.
Yes, sir.
Increases.
Yes, sir.
Relieves on lying on the right side.
Yes, sir. So
Yeah.
possibility of pathology on the left side of the lung, sir.
Okay.
Because
Okay.
of increase, like because of gravity, there is increased intrapulmonary shunting if possible.
Yeah.
And
What is happening is when it lies on the left side, no, the right side lungs is able to expand and oxygenate.
yes,
That is the reason his symptoms are predominant. So those probably is having a significant damage to the left side.
left side.
What is platypnea?
The platypnea is dyspnea on sitting position, when sitting position, sir.
Sitting or maybe standing or sitting.
Standing, yes, sir.
Can you give one or two
Yes, sir.
examples?
Yes, sir. Platypnea, there could be coexisting either a left atrial myxoma or a extensive left upper lobe collapse or hepatopulmonary syndrome commonly, sir.
Common disorder, do you think? One common disorder. See, what is happening is most probably either an ASD or a patent foramen ovale.
Yes.
It is more likely that the shunting can occur. No?
Yes,
It is a more likely chance.
yes.
Okay, so this patient has got a progressive breathlessness 6 months and looks like significant pathology on the left side of the chest. Okay, go to the next slide, sir. Yes, okay, proceed.
Yes, sir. The patient also complained of cough with expectoration since 6 months.
Okay.
It was, gradually progressive with no specific aggravating factors and mildly relieved on taking some cough syrups. The sputum was scanty, whitish mucoid in consistency, which was non-foul smelling. He also complained of 2 episodes of blood streak sputum 5 months ago, which was predominantly bright red in color and was mixed clearly with a mucoid sputum.
Stay there. Don't change the slide. Don't change the slide. See, 6 months cough, sputum, scanty, whitish, mucoid. All these suggest what? What do you think? With this, whatever possible.
Parenchymal involvement, it suggests, sir.
Okay. What suggests parenchymal involvement?
Presence of the cough with the sputum, the expectoration that is there. That is
parenchymal involvement may not be. You cannot say straight away. It looks like definitely the lower respiratory tract is involved because there is history of wheeze. There is gradually progressive cough sputum means the disease is progressing. Only thing is it is almost ruling out that it is not a suppurative lung disorder.
Yes, sir.
Because there is no significant sputum or maybe non-foul smelling sputum suggests what?
Foul smelling sputum suggests there is anaerobic bacterial infection. So most
Can you tell some disorders which produce as foul smelling sputum?
Sir, lung abscess, bronchiectasis.
Okay. Maybe something like bronchopleural fistula. It is possible. There is 2 episodes of blood streaks.
Yes, sir.
So what is the significance of that? Bright red mixed with mucoid sputum.
So this suggests there is.
Because there is some amount of scanty hemoptysis.
Yes, sir.
Yeah.
So one could be if there is carcinoma because he's elderly and background history of some weight loss is also there. So
we will see later on. With this only available, it looks like it is not a severe major bleed.
Yes, sir.
There is a small amount of blood going on.
Yes,
the streaking of blood, no, it suggests maybe a bronchial mucosa is slightly bleeding. Possible in this man, 61-year-old, either pulmonary tuberculosis or malignant disorder, we don't know, or even a fungal infection. It is possible. Do you know what is bronchiectasis sicca means?
Sir, dry bronchiectasis wherein there is the involvement of the predominantly the upper lobes, there is the drainage happens and they don't produce much of sputum.
Which condition it will due to? Bronchitis occurs due to what condition?
Tuberculosis, pulmonary tuberculosis.
Post-pulmonary. What is proximal bronchiectasis, which may present like this?
Endobronchial tuberculosis may present.
No. Proximal bronchiectasis. Heard of that term?
No,
or central bronchiectasis? Aspergillosis.
Aspergillosis.
Yes. Such type of scanty sputum with streaked, can occur in either tuberculosis or maybe malignant disorder of the lung. Okay. So pulmonary tuberculosis is still possible. We don't know. You told one history that there is no history of P&D.
Yes, sir.
What does it suggest, sir?
It rules out a cardiac cause for the breathlessness, sir.
P&D suggests you of what?
Left heart failure, sir.
Left side cardiac failure. So what respiratory disorders mimic P&D? They can mimic, some respiratory condition, same attack.
Yes, sir. Nocturnal cough variant asthma can.
Yes, very good. Even COPD exacerbates, isn't it? They can, and a repeated attack can occur like that. Only thing you have to differentiate.
Yes.
Okay. Right. So next slide you go, sir.
Yes. There is history of hoarseness of voice in 6 months, which was non-progressive in nature. There is associated history of unintentional weight loss, about 15 to 20 kgs in the last 6 months, with the associated reduced appetite. There is also history of some runny nose and sneezing on exposure to dust, and since many years, because he works in the farm, so there may be some allergic component. That
what these things suggest to you, sir?
This suggests that this is alarming, sir. So there are red flag signs of unintentional
hoarseness of voice. What may be the reason for that?
Involvement of larynx, sir. Either it may be the muscular involvement of the larynx or the neural nerve supplying the larynx, sir.
Do you think it is neuronal or muscular or some other? Is it the laryngeal tuberculosis possible?
Possible, yes, sir. Laryngeal tuberculosis is a possibility here, sir.
Okay, but they would have had some pain.
Pain, yes, sir.
Yes, dysphagia, pain would have been there. It is not there. Any other way hoarseness can be explained?
Involvement of nerves, sir, or any recurrent laryngeal nerve involvement.
Yes.
Because
it's possible that it may be recurrent laryngeal nerve involvement, unless they say it's something like a thyroid, because he has got some 15 to 20 kgs of weight loss. Can you tell some disorders with such a long, significant weight loss? 15 to 20 kgs in the 6 months.
Yes, sir. One is pulmonary tuberculosis commonly.
Okay.
Second would be a malignancy. Most commonly, with this history, would think of a bronchogenic carcinoma.
Any internal malignancy? Maybe we don't know.
Any internal malignancy, sir.
Any other disorders with so much weight loss?
Thyroid, hyperthyroidism, thyrotoxicosis can have this unintentional.
Okay. Mention the disorders which present as significant weight loss. Don't bother about this case.
Okay, sir.
Other disorders with so much weight loss. Any other endocrine disorder? See, uncontrolled diabetes.
Uncontrolled diabetes.
Yes, isn't it?
Yes, sir.
Any infective disorder?
Retroviral disease can
be
something like this.
It should always go infective, metabolic, endocrine, neoplastic disorder. Under that, each category 1 or 2 you should name. So 15 to 20 kg weight loss, maybe tuberculosis, internal malignancy, the retroviral state, we still don't know. It is still possible. So we have got so far cough, sputum, breathlessness, hoarseness of voice, weight loss, 4 dominant with scanty hemoptysis. All suggest either a pulmonary parenchymal or a bronchial disorder which is going on, predominantly affecting the left side. So far, whatever going on. Okay, proceed, sir. So do you think it is something to do with his occupation?
Occupation unlikely to cause hoarseness, unintentional weight loss is unlikely.
Do you think it is some bronchopulmonary aspergillosis because he's a farmer exposed to dust, fungi? We don't know. Farmer's lung-like. But he cannot explain the hoarseness and so much weight loss.
Weight loss, yes, sir.
It's likely that they will have. They will have predominant presentation of cough, sputum, breathlessness. Okay, right, proceed. Yes.
So there is no history suggestive of orthopnea, paroxysmal nocturnal dyspnea, or swelling of the feet. There is
Okay.
no history of any chest pain, no history of
Right.
fever or evening rise of temperature or night sweats. There is no
Okay.
history of contact with people with pulmonary tuberculosis. No history
Okay.
of giddiness, palpitation, fainting episodes. There is no history of
Okay.
difficulty in swallowing, regurgitation, or vomiting of food. There is no history of any headaches. No history of sensory disturbances, blurring of vision, diplopia, or tearing from the eyes. Patient had been evaluated for the same complaints, but he was not on regular follow-up for the same.
Hello?
Yes, sir.
Can you hear me? Yeah.
Yes, sir.
Yeah. Go ahead. Okay.
The past history, the patient
Yes.
has a note.
Go to the previous slide. One more previous slide. Yeah. See, no, not this, not the next slide. Next slide.
Yes, sir.
So no PND, swelling of feet, chest pain, fever, giddiness, etc., etc.
Yes,
So what you are aiming at all these?
Sir, we are trying to localize to a system, sir. So here,
Okay.
there's a cardiac system that is being ruled out.
Okay.
Neuronal involvement, the neurological involvement is like unlikely here, sir.
Okay.
It localizes us to the respiratory system.
Is it swelling of feet is common in respiratory? Possible sometimes?
Possible with if there is COPD with cor pulmonale, then they may develop a swelling of feet. That is,
Why?
could be because of right heart failure, sir.
Yes. Pulmonary hypertension, cardiac failure.
Yes.
Any other reason? Swelling of feet in a patient of respiratory disorder. Other 2-3 mechanism. Patient has got long-standing cough sputum. Bronchiectasis, can they develop?
Yes, sir.
How? If they develop amyloidosis, kidney with nephrotic, or they should have an SVC or IVC obstruction of some reason, or a hypoproteinemia due to significant sputum protein loss, then it is possible. Otherwise, not possible. But this does not have anything. Okay, next slide.
Yes, sir.
Okay.
Patient is a known.
Previous slide shows what? The patient was evaluated something?
Yes, sir. He was evaluated for the same complaints on an OPD basis, but he did not come for regular follow-ups with the investigation, sir.
So nothing was confirmed.
Confirmed with.
Okay. Right. Next. Yeah.
Patient is a known case of type 2 diabetes mellitus since 4 to 5 years. He is on metformin and glimepiride fixed dose combination.
Okay.
There's no history of hypertension, tuberculosis, bronchial asthma. There's no history of any admissions or surgeries in the past.
What do you think? This type 2 diabetes, anything to do with this case or?
Sir, there could be, if it is uncontrolled, it could cause an immunosuppressed state and he may not mount classical features of like fever.
What they are prone to develop?
Secondary
respiratory problem in a diabetic.
Recurrent infections they are prone to develop, sir.
Like? Which infection? What are the common respiratory problems in a diabetic?
Staphylococcal like
pneumonia. You can have pneumonia, isn't it?
Yes, sir.
Gram negative, gram positive. Any other? You can have tuberculosis.
Tuberculosis, yes, sir.
Maybe even fungal. Isn't it? It is possible that they may develop all this. Okay, yes. Right. Even melioidosis, so many other infections are possible in them. Okay, right. Proceed.
Coming to the family history, there's no history of any similar illnesses in the family.
Okay.
There's no history of diabetes, hypertension, heart disease, tuberculosis, or malignancy that was diagnosed in any of the family members.
Can you tell some respiratory disorders which run in the family?
Sir, alpha-1 antitrypsin deficiency with like emphysema that can run in families, sir.
Okay, any other? Some family association with respiratory disorder.
Cystic fibrosis.
Yes. Cystic fibrosis produces what? Respiratory problem.
It causes a bronchiectasis.
Okay. Any other? See, asthma possible.
Asthma, yes, sir.
Isn't it?
Yes,
is it pulmonary tuberculosis with contact possible?
Yes, sir. Possible.
Yeah. See, if there is a tuberculosis is very important.
Yes, sir.
Runs in the family, no.
Yes, sir.
So allergic disorder possible. Malignancy rare, possible they say.
Yes, sir.
Tuberculosis definitely possible. Okay. Alpha-1 antitrypsin deficiency possible. Cystic fibrosis possible, including some sort of a ciliary disorder, motile cilia. Can you tell some disorders of ciliary dysmotility?
One is Cartagener's syndrome, sir.
Yes.
Then
Young's, Cartagener's. They're still
syndrome.
possible, isn't it? Yeah.
Yes, sir.
Okay. Proceed.
The personal history, the patient consumes a predominant vegetarian diet. His appetite is reduced. He has a disturbed sleep.
Okay.
Bowel and bladder, there is increased frequency of micturition at the night, about 6 to 8 times. And he also complains of passing stools only once in 2 days.
Right.
Coming to the habits, he is a current smoker. He consumes about 1 pack of BD per day and has been consuming it for the past 30 to 35 years. The smoking index of 720. Also a history of chewing tobacco for the past 30 years.
So what do you think with this?
So here there is evidence of uncontrolled diabetes because of these osmotic symptoms is a possibility here because of increased frequency of micturition at night.
It's increased frequency possible.
Yes,
I don't know whether it is frequency or amount is increased. What disorders present as increased frequency of urine at night?
More BPH commonly present.
Yes. Drug-induced BPH, early cardiac failure. If there is amount of urine also increased, it may be because of that.
Yes.
Otherwise, we still don't know.
Yes,
okay, next, what do you think? Smoking.
Smoking is significant. So the smoking index is more than 300.
What do you mean by that smoking index?
Sir, number of packs of number of cigarettes taken per day into the total number of years. Sir.
That is pack year. The smoking index is slightly different. It calculates so many things, whether he missed in between, he stopped, whether he decreased the pack, whether in between, there any way, like that, so many things are taken into account. Anyhow, in general, he is significantly a smoker.
Yes, sir.
Isn't it? So, yes, what is the significance of this?
Predisposes to like more than a value of more than 300 predisposes to increased risk of bronchogenic carcinoma.
How many times the smokers are at risk of developing bronchogenic carcinoma? Do you know? It's a significant number of pack years. Somewhere around 30 times they say. Okay. Right? What disorder smoking produces? Respiratory system.
One could be chronic obstructive pulmonary disease, chronic bronchitis or emphysema.
Okay.
Then it can cause bronchogenic carcinoma as the malignant conditions.
Okay.
Then smoking can also cause recurrent URTIs can be there, post-nasal drip can be there.
They are prone to develop tuberculosis.
Yes, sir.
Even idiopathic pulmonary fibrosis. Right? Is passive smoking risky?
Yes, sir. That also increases the risk, but not to the same extent as active smoking. Around 1.5 to 2.5 times, I think it
is. Yes. There is a risk of developing malignancy, etc. Right? Yes. So he has a significant history of smoking, and we have to attribute what it can predispose after the total history.
Yes.
Okay. Alcohol, anything? No.
No, sir. He denied any alcohol.
Next slide is what? Next slide.
Provisional diagnosis.
Okay.
So at the end of the history, I would like to think of the involvement of the respiratory system.
Okay.
Either parenchymal or pleural, both are possible.
Okay.
But with the history of significant weight loss, cough with expectoration and breathlessness, I would like to think of the possibilities of a lung malignancy predominantly affecting the left side of the lung. The other possibility would be a pulmonary tuberculosis with a coexisting laryngeal involvement because of the hoarseness of voice and significant weight loss. Interstitial lung disease unlikely to cause so much weight loss and.
Now, what points favor it is a respiratory disorder? After your full history, yes, what points favor respiratory disorder?
Cough with expectoration.
Okay.
And breathlessness, sir, without
significant cough sputum. Yes. Breathlessness is there, of course.
Yes, sir.
And one more history is also wheeze.
Wheeze, yes, sir.
See, more likely. Wheeze suggests what, sir?
We suggest narrowing of the bronchial edema, bronchial wall edema, sir.
No. It may not suggest always bronchial. It suggests medium size airway narrowing. What disorders present as wheeze?
Most commonly, asthmatics, bronchial asthma.
Okay.
Then rarely cardiac asthma can also be present, sir.
No, that is rare, possible. Any other common disorders, respiratory wheeze?
Yes, sir. One more is acute bronchitis can present.
Yes, acute bronchitis, chronic bronchitis, bronchial asthma, pulmonary eosinophilia, aspergillosis, all can present as wheeze. This patient had any of it. May be because of either evidence of smoking or an infection, we don't know. So significant cough, sputum, breathlessness without cardiac symptom, possible. Airway, parenchyma or pleura, it is written.
Yes, sir.
Why pleura?
Because of the breathlessness and the trepapnea that was present on only the lateral side, which improved on lying down.
That may not suggest pleura. It suggests significant pathology on the left.
Yes, sir.
What always suggests pleural disorder? What disease or what symptom?
The dry cough and breathlessness mainly, without any
pleuritic pain.
Pleuritic pain, chest pain.
If it is there, effusion significant, the pain need not be there.
Yes, sir.
Pleuritic pain, definitely yes. So pleura, we are not very sure. Airway parenchyma possible because cough, sputum, wheeze, most probably on the left side. Now it is written lung malignancy, means bronchogenic malignancy.
Yes,
can you explain his symptom?
Yes, sir. If it is a malignancy, there is history of cough.
Okay.
With expectoration.
Okay.
And breathlessness may be because of a chronic, if there is a metastasis.
What is the reason for breathlessness in a lung malignancy?
How to explain? Could be a collapse. One could be a
significant damage causing collapse of the lung. Okay, possible. Any other ways?
One could be a metastasis causing an effusion that can cause breathlessness.
Okay. Other reasons for breathlessness, yeah.
One more could be extensive involvement with the narrowing of the airway that can cause breathlessness.
There is a huge mass pressure effect. It is still possible. Any other way? If there is a diaphragm palsy, but it should be bilateral.
Bilateral, yes, sir.
Otherwise, less likely, isn't it? Yes, so either there is an airway obstruction, or there is an effusion, or a diaphragm.
Yes.
Breathlessness, unless there is a cardiac involvement, it is less likely.
Yes.
So that can be explained. Hoarseness of voice, do you think can be explained with lung malignancy?
Sir, if there is involvement of the Horner syndrome,
No. Hoarseness of voice.
Lung malignancy, there could be some METS2, there's some lymph node involvement, spread, loco-regional spread to the lymph nodes that can cause a compression and cause a hoarseness of voice.
Compression of what? No, you better say there is a mass which is on the left recurrent laryngeal nerve.
Oh, yes, sir.
Mediastinum, mass, left recurrent laryngeal nerve. No,
yes,
that can cause. Otherwise, you should say there is something other pathology in the larynx also.
Yes,
so you can explain cough, sputum, you can explain breathlessness, you can explain weight loss, you can explain hoarseness.
Yes.
If it is a lung malignancy, possible in a smoker. Next, pulmonary tuberculosis. Can you explain all this?
Yes, sir. It can explain all of this, sir.
What is not there favoring tuberculosis?
One is the breathlessness, unlikely with tuberculosis.
Fever, is it there?
Fever is not there.
No.
But, that could be because of uncontrolled diabetes or coagulation.
No. Even if it is uncontrolled, fever would have been there.
Okay.
Definitely, yes. So that is not there.
Yes, sir.
Otherwise, you can explain cough, sputum, breathlessness with the lung involvement and larynx possible. ILD, very unlikely, sir.
Yes, sir.
ILD is very unlikely to explain all those symptoms. So it's still possible that it may be a bronchogenic carcinoma with the whatever, because of hoarseness, it's still possible there is a mass mediastinum or a pleural pathology. Tuberculosis, next possibility is present with the diabetes mellitus type 2.
Yes.
Agreed? Right.
Yes, sir.
Okay, proceed. Yes.
Dental physical examination. It is an elderly male, conscious, cooperative, well-oriented to time, place, and person. BMI was 19 kg per meter square. There was bilateral grade 3 clubbing that was present. There is no history of there's no pallor, icterocinosis, lymphadenopathy, or pedal edema that was noted.
Okay.
There's a keloid of 3 into 6 centimeter over the anterior aspect of the chest, overlying the manubrium.
Okay.
The vitals, the BP was 130 by 70
Now,
millimeters.
with this general examination, no?
Yes, sir.
What is striking to you?
The one is the BMI and the grade 3 clubbing, that is very striking, sir. An elderly male with a clubbing and low BMI.
So can you tell some respiratory disorders of clubbing?
One is the suppurative lung diseases like bronchiectasis, lung abscess. One more could be bronchogenic carcinoma.
So you better say parenchymal disorder,
yes.
bronchiectasis, lung abscess, bronchopleural fistula, bronchogenic carcinoma.
Yes.
ILD, parenchymal disorder, pleural disorder,
mesothelioma
and empyema.
Empyema
thoracis, mesothelioma pleura, maybe secondary disposal. So patient has got grade 3 clubbing. What else you should look for?
I should look for presence of hypertrophic pulmonary osteoarthropathy for tenderness in the.
How to look for pulmonary osteoarthropathy evidence? What do you look for? What do you mean by that term?
Sir, there is
thickening
and
enlargement of lower part of long bones, presenting as pain like wrist, minimal effusion into the joint, and restriction of movement. Okay. So, can you tell which type of bronchogenic carcinoma presents as clubbing and which as pulmonary osteoarthropathy? Predominantly, statistically, may not be very.
Sir,
it is
pulmonary osteoarthropathy most common with small cell carcinoma of the lungs.
No, may not be. Yeah. Non-small smell is always clubbing. Adeno may be with hypertrophic. Small cell carcinoma predominantly presents as paraneoplastic. Agreed? Right. Okay. No lymphadenopathy is there. So, which lymph node you are interested?
One is the cervical.
Yes. It is not there.
No, sir, not there.
Okay. Proceed. So, he has got clubbing. Okay. Right. Go ahead.
Coming to the examination, the heart rate was 110 beats per minute, regular.
Right.
Normal in volume with no radial or femoral delay with peripheral pulses being well felt.
Okay.
The blood pressure was normal, 130 by 70 millimeters of mercury in the right arm, brachial artery, supine position.
Okay.
Respiratory rate was 24 beats per minute, abdominothoracic.
Right.
Temperature was 98.4 Fahrenheit with a saturation of 95% on room air.
Okay. Vital signs are relatively okay, except that heart rate is slightly high.
Yes, sir.
Okay, proceed.
Coming to the systemic examination, the respiratory system, the upper respiratory tract appears normal. There's nicotine staining in the oral cavity and in the hands.
Which one?
Nicotine stains.
Okay. Right.
Lower respiratory tract.
What other oral URT you should look for what? Upper respiratory tract, you should look for what other things in a RS case?
One is the septum, if there is any
deviated nasal septum.
Yes.
Any other important things? You should look for sinus tenderness.
Sinus tenderness, yes, sir.
Because sinusitis can be associated with bronchiectasis, no?
Yes,
Which condition?
Sir, Carter-Jenner syndrome.
Yeah, you should look for URT.
Yes.
So look for sinus tenderness. Look for an infection, including larynx. Okay. And of course, oral candidiasis, we don't know. It may be something like retroviral. Associated that. Our patient may be on steroid. Respiratory disorder. Okay. Right. In a patient of lung abscess, better look for the dental. Whether it's a tooth abscess or a gingivitis. Okay. Right, sir. Okay. Proceed.
Lower respiratory tract and chest inspection. The trachea is debated to the left.
Okay.
The apical impulse was not visible. There is supraclavicular and infraclavicular hollowing that was present on the left side.
Okay.
The chest movements appeared equal.
Okay.
There is a keloid there is no dilated veins, pulsations or scar that was present.
Yeah, keep it like this.
Yes, sir.
So what do you think with this inspectory finding? How do you make our trachea deviate to the left?
Sir, we look for the trail sign, sir.
What is that?
The undue prominence of the sternocleidomastoid muscle deviation, undue prominence of sternum.
Why it becomes like that?
So there is the relaxation of this pretracheal fascia that is
Okay.
involved.
Okay,
So
okay,
that
okay.
time there is,
Yeah, possible. Which head of sternocleidomastoid do you know? Sternal head, clavicular head? Huh?
we look at the sternal head.
No.
Clavicular head, sir. Your clavicular.
Yes.
Clavicular.
Right. So there is trachea deviate to the left, apex not seen,
Yes, sir.
supra-infraocular hollowing.
Yes, sir.
So suggests
there is a volume loss on the left side with the fill of the trachea to the same side, sir.
So what disorder will be like this?
One could be an apical upper lobe fibrosis.
Okay. Even apex is not seen. So
Not
it may be full one side.
Yes, sir.
Okay. Anyway, any other?
One could be a mass with a collapse that could be there, sir.
Mass we don't know. Collapse, fibrosis.
Collapse is,
or is it, do you think, pathology on the right side, which is pushing?
Yes, sir. It could be a right side pleural effusion also that could be there.
But what is not there to suggest? See, written chest movements are equal.
Movements are equal, yes, sir.
So we don't know. We expected the chest movement to decrease on the left.
Yes, sir.
Isn't it?
Yes, sir.
What disorders cause significant volume loss?
One is fibrosis, one could be collapse, sir.
What fibrosis? You should say pulmonary fibrosis, pleural fibrosis, collapse. Collapse usually less because it is a recent event. Fibrosis are more chronic. So they have more problem of significant volume loss. Which disorders of the lung, the trachea, mediastinum is central. Which disorder of respiratory disorder, mediastinum is not shifted.
Bilateral effusions can...
that's all very less likely, sir. Possible.
Yes, sir.
Common acute condition.
Yes, sir.
Which condition? Certain disorders, trachea, mediastinum not shifted at all. Consolidation. Not shifted. Isn't it? Acute bronchitis not shifted. Bronchiectasis, bronchial asthma not shifted. So this, even in simple emphysema, it is not shifted.
Not shifted, yes, sir.
Okay. ILD not shifted. Whereas all other effusion, pneumothorax, it is shifted. So you should be able to say trachea shifted to the opposite side, same side, central. Okay? Right. Proceed. Yes.
Coming to the palpation, the inspectory findings were confirmed.
Okay.
There's no local rise of temperature or tenderness that was noted anywhere. The apical beat was not felt.
Okay.
The movements were reduced in the left mammary and the infrascapular areas.
Okay.
Measurement, the hemithorax, the right hemithorax was 34 centimeter. The left hemithorax was 34. There is the chest expansion reduction of only 1 centimeter was the chest expansion.
Okay.
The spinoscapular distance was equal on both sides, with a reduced tactile fremitus on the left mammary, axillary, infraaxillary, infrascapular, and interscapular.
What do you think, sir? There is decreased movement that is expected, I think.
Yes, sir. It is expected.
Okay. What is something, this measurement, do you think something funny or do you expect something different?
Since we are thinking of a fibrosis or volume loss that is there, so left side there should be a little reduction in the hemithorax.
Yeah, there should have been a left hemithorax. Less, isn't it? It is written as same. Yes, chest expansion is 1 centimeter. What is your comment?
So there is reduced expansion of the chest.
What is the normal chest expansion in male and female? Do you know?
So about 5 centimeter in male.
5 to 7, 3 to 5.
3 to 5.
What disorders significantly reduce chest expansion? Forget about unilateral disorders. Which other disorder chest expansion is significantly decreased?
COPD.
Emphysema. Yeah. Okay. Then. ILD.
Yes, sir.
Ankylosing spondylitis. In these disorders, significantly the expansion. Here also it is reduced. Yes, you might have been a chronic smoker, we don't know. You expected less on the left, but it is not written.
Yes, sir.
Or your slides are not seen.
Yes, sir.
Slides are not seen.
Yes, sir.
Okay, now. Oh, 1 minute. Yeah, yes, right.
Yes, sir.
That spinoscapular and spinoacromion looks funny because if there is a volume loss, no, you expect it to be different. Whatever it is, tactile firmness reduced.
Yes.
What is the understanding of yours?
Sir, there is probably there is a effusion.
What disorders the tactile local firmness is reduced?
Sir, one is the emphysema, effusion.
Unilaterally reduced.
Unilateral.
Effusion. Okay, then
there could be a collapse, sir.
Collapse. Yes.
Consolidation.
Consolidation. It is
usually increased.
Increased.
Fibrosis.
Yes. Parenchymal disorder. Fibrosis. Collapse. Pleural disorder. Pleural fibrosis. Effusion. Pneumothorax. They are significantly reduced. Okay. Right. Okay. Proceed.
I was thinking if there could be an effusion that may cause this like expansion of the left hemithorax.
What other finding you expect if there is a fluid on palpation? There would be an intercostal fullness.
Yes, sir.
We don't know, it is not there. So you should look for either there is a crowding of rib present or not. Do you know what is crowding of rib? Have you heard of this?
Yes, sir.
How do you make out? Crowding of ribs. Because significant pleural or pulmonary fibrosis now, they produce crowding. That means the space between the rib becomes less.
Yes.
So you have to accommodate your fingers on both sides. See which side it is easy to accommodate, which side they overlap.
Yes, sir.
So we expect that, but effusion difficult to say with this finding right now.
Yes, sir.
Okay, right. Because still the percussion we don't know.
Yes, sir.
Okay, proceed.
On percussion, there is a dull note that was noted over the entire left hemithorax.
Okay.
It's difficult to make out the nature of the dullness, like whether it was stony or woody dullness, sir.
Why you want to make out?
Because it might help us in the cause for the dullness.
Woody dull note, which condition?
In consolidation, we get a woody.
Stony.
Sir?
Stony dull note.
In effusion, sir.
What do you mean by that? How do you appreciate that stony dull note?
Stony dullness, we compare it with the wood. Stony dullness, we percuss with the thigh and compare it with the.
So what you should say, stony dull note, no? There will be resistance to your percussion.
Okay.
You feel resistance. It is difficult to percuss.
Yes, yes.
That is how it is stony. Otherwise, you cannot compare thigh in the exam at all.
Yes, sir.
Right? Yes. Okay. Dull note is present on the full left side.
Yes, sir.
Right?
Yes.
Which condition you will have? Dull note. Percussion note dull.
Effusion.
Okay.
Parenchymal, it will be consolidation, extensive consolidation.
Okay.
Or a fibrosis.
Okay.
Fibrosis. Pleural, either effusion or
pleural fibrosis. Any other condition? Mass.
Mass. Yes, sir.
May not be full one side. Localized, it is still possible.
Yes, sir.
So either it is consolidation, mass, fibrosis, pulmonary,
yes,
pleural effusion or pleural fibrosis. Now, right now it looks somewhere like this. Okay, right. So what do you think with this finding? What you are so far do you think? See, there is volume loss.
Yes,
decrease vocal fremitus on the left. So what disorders are possible? Do you think it is consolidation?
Sir, unlikely, sir. Think
impossible.
And collapse.
So do you think it is pulmonary fibrosis?
Yes, sir. Possible, sir.
Possible. Pulmonary collapse?
Collapse. Chronic.
We don't know. Still collapse. We don't know.
We don't know.
Mass? Difficult to say right now. Pleural, do you think pleural effusion?
Sir, pleural effusion usually.
It cannot, no, sir. There is volume loss.
To the opposite side, it won't pull it to the
volume loss, mediastinum shifted to same side. Not possible. So either it is pulmonary fibrosis, collapse, or maybe pleural fibrosis. We don't know.
Yes, sir.
Only thing is that rib crowding is not mentioned.
Yes.
Okay, right. Proceed.
The liver dullness was noted in the right fifth intercostal space in the mid-clavicular line, 7th in the mid-axillary, and 9th in the scapular line.
Okay.
Pedal percussion, it was resonant. The excursion was one intercostal space.
Okay.
The cardiac dullness could not be appreciated. The trop space, however, was tympanic on percussion.
So, what is the significance of this? Trops tympanic.
It rules out a significant effusion on the side.
Yes, less likely that there is significant unless you say
Yes.
loculated or that is all later on with the investigation, right?
Yes, sir.
What do you expect this trough space to happen in a patient of left-sided collapse or fibrosis? So much whole hemithorax. Expect it to be lifted up.
Lifted up, yes, sir.
Because the lower lobe is so much, so ideally it should be lifted. That is not mentioned here. You
Okay.
expect it to be lifted up. Okay? Right. Okay, proceed.
Yes. On auscultation, the breath sounds are reduced in the left side, which is the mammary, infraxillary, interscapular, and infrascapular areas. The tubular bronchial breath sounds that were heard in the left infraclavicular area.
Okay.
Vocal resonance was reduced in the entire left hemithorax.
So what do you think?
Tubular bronchial breath sounds.
See, that is reduced breath sound on the left
with
mammary, infraaxillary, infrascapular, interscapular. Tubular breath sound, infraclavicular.
Yes.
Vocal resonance reduced left.
Yes, sir.
So, which way you can explain all this? First, you tell the reduced breath sound causes left.
Reduced breath sounds in the pulmonary cause, there would be a pulmonary fibrosis or a pulmonary collapse, left-sided collapse or a fibrosis, sir.
Okay.
It could be a pleural fibrosis or a pleural effusion.
Okay.
Or a pneumothorax in the left
Yes.
side.
Yes. Now, so those are the possibilities.
Yes, sir.
Now, tubular breathing present left infraclavicular. Can you tell the causes of tubular? I think what is tubular breathing?
Sir, tubular breathing is when the inspiration and expiratory phases are equal and there is a gap.
It is a type of bronchial breathing.
Bronchial breathing, yes, sir.
So what is bronchial breathing? Bronchial breathing means dash. No, don't tell the criteria.
Yes, sir.
Should say abnormal type of breathing which is harsh and aspirating in quality.
Aspirating in nature, yes, sir.
Criteria are whatever told.
Yes, sir.
So tell the causes of tubular breathing.
Consolidation.
In general, okay.
It could be physiological or it could be pathological. Physiologically, we can hear it over the trachea.
No, that don't bother about that.
Pathological, one is the consolidation.
Okay.
Or a collapse of the patent bronchus.
That is not a usual scenario. That is rare. Yes. Unless there is a mass pressing, no. Yes. Then yes, it can conduct.
Yes. Yes. Then usually at the upper level of the pleural
effusion with egophony, whatever it is. Then can pulled trachea pause?
Pulled trachea, yes. Pulled trachea syndrome, yes.
Yes, which is predominantly on the right, rarely on the left. Yes. Then is it possible that it may be an Ewart sign? Yes, tubular breathing, have you heard?
Yes, sir. Yes, sir.
Active pericardial effusion on the left.
Bronchus, yes.
And rarely it may be a part of D spine sign.
Yes, sir.
I heard of that?
Yes, sir. D spine sign.
That can also tubular breathing or maybe whispering pectology. So he has got a tubular breathing on the left infraclavicular.
Yes, sir.
Okay. Right?
And there is a reduced vocal resonance.
So what do you think he may be having with all this? Do you think it is pleural effusion?
Sir, unlikely.
Well, reduced breath sound, dull note, tubular breathing, above the level vocal resonance. Why not?
Sir, but trachea is pulled towards the
yes, mediastinum is totally shifted to same side. Yes. Do you think it is any additional sound have they mentioned? No.
There is no additional sound, sir.
Absent.
Absent.
Additional sound is absent.
Absent, yes, sir.
So additional sound absent almost rules out fibrosis.
Fibrosis.
Okay. So do you think it is collapse?
Possible, sir. It should be.
If reduced breath sound possible. Lower lobe or upper lobe, whatever it is. Vocal resonance reduced left hemithorax. Only thing is tubular breathing. You expect. What do you expect the breath sound in collapse?
Like reduced breath sound. We don't
absent.
Absent, yes, sir.
See, all other feature, tracheal shift may favor.
Because of full trachea, we may have the
infrared. Full trachea possible. Yes, so possibilities are consolidation out, yes, full trachea possible.
Yes, sir.
Isn't it?
Yes, sir.
Massive effusion above the level tubular breathing out.
Oh, yes, sir.
So, do you think it is left-sided pulmonary fibrosis?
Usually, if there is a pulmonary fibrosis, then there will be some added sounds that will be there,
Yes.
so like some fine cuts
So, no evidence at all.
of any.
Do you think it is full pulmonary collapse? Left.
Possible, sir. Yes,
You
sir.
expected the breath sound to be absent.
Absent.
So, how do you explain with this that there is
Collapse, yes, sir. Collapse with there is some amount of patent bronchus.
what you should say is, if possible, there may be a mass conducting the sound with an underlying the compressing
yes.
in the upper lobe. It is possible
Yes,
that the mass can conduct the bronchial sound. The rest of the lung being collapsed.
correct.
You can explain tracheal shift, decreased breath sound, no added sound. Everything is possible. Okay, so it looks like at this level that is a left-sided full collapse. It may be a mass conducting the sound.
Yes, sir.
So you can explain almost all of the findings.
Yes,
right? What additional finding you want to look for in favor of that there is maybe an upper lobe or a mass pressing on the main bronchus? What additional finding you should look for? You should look for mediastinal widening, SVC sign obstruction,
okay,
left Horner,
yes.
and Horner is possible, left diaphragm palsy. Not very common, but whenever a mediastinal mass is suspected, please look for those signs. Mediastinal widening, so percussion on either side of the sternum and on the manubrium, lower part, SVC obstruction manifestation like neck vein distended without waves, okay, Horner, right? Because there is hoarseness.
Yes.
It is possible that it may be a mass somewhere with a collapse. Yes. And of course, phrenic nerve palsy on the left. How to make out unilateral diaphragm paralysis?
Sir, we asked there will be...
See, bilateral diaphragm paralysis, patient will be orthopneic.
Orthopneic, yes, sir.
That will be paradoxical movement. Unilateral, difficult to make out. There is a sign called Litton's sign. I don't know whether you heard of that.
No, sir.
There is normal during inspiration, the diaphragm moves down.
Yes, sir.
But it moves down bilaterally. So difficult to make out except in a thin individual. So stand or look tangentially at the lower part of the chest during breathing. Normally both sides should move down.
Yes, sir.
If one side of the movement is absent, then that side abnormal diaphragm is not moving down. That is called Litton's sign.
Yes, sir.
It is not a usual thing to make out, but difficult to make out, but it is possible. Okay, that is called phrenic wave or a Litton sign or no. So you should look for all these: mediastinal mass, SVC obstruction, Horner, diaphragm palsy. Along with these, whenever a patient of this type comes, especially supraclavicular and cervical lymph nodes. Okay, proceeds. Yes. So far the diagnosis looks like left-sided pulmonary collapse with a mass present maybe in the mediastinum or the upper lobe. What is that upper lobe mass will produce usually?
Pancoast tumor.
So what they will have?
Sir, they'll have they'll present with the Horners.
They will have fullness in the supraclavicular area. Okay, tenderness over first and second rib because of rib erosion, and C8T1 involvement because of the lower part of brachial plexus. Okay, proceed.
Yes, sir.
Yeah. So far our clinical diagnosis is over.
Yes, sir.
The smoker, cough, sputum, weight loss. Clinically, it fits almost to this.
Yes.
Okay, proceed.
Systemic examination, cardiovascular system, the heart sounds were heard, there was no any murmurs. Cranial nerve, central nervous system examination, the higher mental functions are normal. There are no focal neurological deficits.
What do you want to look for in the systemic examination in this man?
Here I would like to look for presence of Horner syndrome in the cranial, the central nervous system examination. Okay.
Suppose if you are asked to look for a proximal weakness, You want to look for your muscle weakness.
Yes, sir. Paraneoplastic
Yes.
Lambert
What type of muscle weakness they can have?
Proximal muscle weakness.
They may have Eaton-Lambert's.
Lambert's, yes, sir.
So in some type of whatever, paraneoplastic. So look for muscle weakness, peripheral neuropathy, etc. Right? Especially with the clubbing, pulmonary osteoarthropathy. Other systems, CVS can be involved with pericardium also. Yes, there can be secondaries in the liver, etc., producing nodular liver. Okay. Look for paraneoplastic. Proceed.
Yes, sir.
Yeah.
I think next would be the investigation, sir.
So, do you think so far the diagnosis you are hitting correctly?
Yes, sir.
What is your clinical diagnosis right now?
Clinical diagnosis right now is a left-sided collapse. Left lobe, probably the upper lobe with the
upper lobe. See, breath sound are significantly reduced. Lower part.
Entire left.
Entire possible because trachea is also shifted. Apex not made out, isn't it?
Yes, sir.
It is still possible with maybe a suspicion of mass because there is a bronchial breathing.
Yes, sir.
And with some mediastinal mass symptoms like hoarseness, etc. Do you think it is still tuberculosis? Can you explain? What? See, I say there is less.
Severe, like if it is a purely endobronchial tuberculosis, that may explain.
Endobronchial tuberculosis, unless a major airway involved,
yes, sir.
Cannot.
But
they will have other symptoms like fever,
yes, sir.
Hemoptysis. It is very streaky. Yes, endobronchial will significantly produce
hemoptysis.
Okay, right. Okay, proceed. Yes, sir. It's time now, or?
Sir,
is it time? No. It is up to 8 o'clock or what? No.
Sir, you can take, you can extend, sir, still 7:30. You can extend till whatever time you want, sir.
Yeah, no, not much time. Don't worry. I will not travel my lot. Yeah. Right, proceed.
So the scheduled time was still 8 o'clock, sir, 6:30 to 8. So you can even extend past 8, so there is no...
No. We'll stop at 8. We'll stop at. Don't worry. He is very afraid of me. Go ahead. Right. Proceed.
Investigations, it showed a normocytic normochromic anemia with a hemoglobin of 9.1.
Okay.
The investigation, the renal function test, the LFT and the coagulation profile are normal.
Right.
Viral serology was non-reactive. 2D echo was normal. Ultrasound of the abdomen and pelvis showed a bilateral medical kidney disease with some free-floating internal echo.
What is this says you of? Medical kidney disease, free-floating internal echoes in the bladder.
Already there is a cystitis, UTI the patient is having, and diabetic nephropathy.
What is this medical kidney disease? Which one? In the whatever background?
Diabetic nephropathy, sir.
How to make out? Diabetic nephropathy, what happens to the kidney? Size?
The kidney size will be enlarged in the diabetic nephropathy.
It may not clinically so much enlarged, but it is not definitely reduced.
Definitely reduced. Yes.
Which other chronic kidney disease? Kidney size is not reduced.
One is the amyloidosis can.
Okay. Then other disorders where chronic kidney disease size is not reduced. Polycystic kidney.
Polycystic, yes, sir.
Retronephropathy. Amyloid, polycystic, diabetic. Kidney size not reduced.
Yes,
so he's having anemia to some extent, maybe because of that chronic disease.
Yes, sir.
And there is some evidence of maybe cystitis with the medical kidney disorder. Okay, proceed.
CCT of the X-ray is.
Yes. What do you think is the X-ray?
The X-ray shows homogeneous.
Read the X-ray.
This shows an
chest X-ray, isn't it?
Yes, sir. Chest X-ray. PA view showing the lungs, the diaphragm, and the.
What about first you have to look at the mediastinum?
Mediastinum, yes, sir. So the mediastinum, we are seeing a pull of the mediastinum to the left.
The trachea and heart.
Heart is
to the left.
Yes, sir. The trachea and heart is pulled to the left.
Okay. What happened to the volume of the lung on the left compared to right?
It is reduced, sir. The volume
Significantly reduced.
Yes.
Isn't it? See the right lung and the left. So what
Yes.
would have happened to the right lung? What do you think it is?
Emphysema on the
yes. Or he may be a smoker with emphysema as such.
Yes, sir.
Okay, right. Then discuss the left side shadow.
Yes, sir.
Homogeneous opacity
completely over the complete left
hemithorax. What else happened?
With the pull of the trachea to the same
What
side.
happened to the diaphragm fundal gas?
Fundal gas is, there is a pull
up.
It's lifted up, sir. Usually the lift will be lower.
So what chest X-ray findings produce homogeneous opacity? What are the disorders which produce homogeneous opacity?
Yes, sir.
In the X-ray?
Yes. Collapse, effusion.
Okay. Most important. Consolidation.
Yes, sir.
Consolidation, mass, collapse, parenchymal. Yes. Plural is usually effusion. So which one do you think?
So I think of a collapse here because there is a pull of the entire mediastinum. There is a shift of the mediastinum with pull of the lower lobe, and there is a
cardiac, not lower lobe, cardiac. So it can occur in fibrosis, no?
Yes, sir.
Why not? Isn't it? Fibrosis also it can occur, huh?
Yes, sir.
Fibrosis invariably does not produce a dense homogeneous opacity.
Yes.
It's not a very typical dense homogeneous unless it is very gross and late. Okay, non-homogeneous usually, invariably. So here's a dense homogeneous possible consolidation.
Underlying consolidation possible, sir.
Possible. What is the classical hallmark of consolidation?
Usually air bronchograms will be present, sir.
What is air bronchogram?
Sir, infiltration of the bronchus.
Infiltration? No.
The infection of the...
No. See, you should say translucency inside an opacity.
Okay.
Corresponding to an air passage. That means there is an air space. The bronchus as such is not involved. Inside, internal. So translucency inside an opacity corresponding to a passage of respiratory passage. So that is visible as it is not there.
It's not there.
And consolidation will not produce volume loss. Consolidation invariably specific to the lobar segment. So no mediastinal shift, no volume loss, air bronchogram present, confined to a lobar segment, consolidation. Right?
Yes, sir.
Significant mediastinal shift, evidence of shrinkage of volume, it has to be either pulmonary collapse, fibrosis. Pleural fibrosis it can cause, but so much mediastinal shift less likely. And pleural pathology or fibrosis causes usually map-like distribution of opacity. Rarely it produces so much dense. So either it is pulmonary collapse or fibrosis. Collapse usually produces a dense opacity. Possible that it may be a left-sided pulmonary collapse. Okay, proceed.
CCT thorax on 10 is done. Showed a ill-defined heterogeneously enhancing mass in the left hilar region in close relation to the left main bronchus extending into its lumen, leading to some occlusion and dilation, which was about 3.8 into 3 into 4.3 centimeter in size, with multiple centrilobular nodules in the left lower lobe and subsolid nodules in the left upper lobe and a calcified nodule in the lateral segment of the right middle lobe.
Okay.
There's a complete filling defect of the left lower lobe pulmonary artery, rest of thrombosis.
So that means there is a mass and of course pulmonary artery. Clot. Yes. Okay. Right. Proceed.
This was the CT images.
Yeah, that you need not. It is already shown now. Go ahead. Bronchoscopy.
Virtual bronchoscopy, like there is a that is there in the left bronchus, main bronchus, the carina here, sir. And the bronchus here.
Okay. Yes. Smokers are prone to develop what type of bronchogenic carcinoma? More likely evidence?
They're more likely to develop Small cell carcinoma.
Squamous, small cell possible.
Squamous cell carcinoma.
What paraneoplastic manifestation associated with squamous cell?
SVC syndrome.
No, paraneoplastic. Hypercalcemia.
Hypercalcemia. Yes.
All others are predominantly oat cell or non-small, small cell carcinoma. Small cell carcinomas are more likely to be associated with so much paraneoplastic, right?
Yes.
Okay, proceed. Yes.
This was the actual bronchoscopic image.
Previous slide, please. Previous slide, please. Some endobronchial mass differential diagnosis. It is written somewhere. Yeah. Okay. Yes. Proceed.
If it is malignant, we are thinking of these possibilities, sir. Most common here it would be because of the background of smoking. We think of squamous cell carcinoma.
Adenocarcinomas are common in whom? Squamous cell carcinomas are predominantly smokers, centrally situated. Yes, adenocarcinoma may be peripherally situated, maybe female, cannot say straight away, but it is possible, right? Yes. Okay.
The histopathologic examination showed a moderately differentiated squamous cell carcinoma, sir.
So, patient is a smoker, you can explain the weight loss, patient of recurrent cough sputum, isn't it?
Yes, sir.
Then predominantly left side collapse, collapse with the mass.
Yes.
Okay, proceed.
This is the PET scan that was done, sir. The PET scan showed a metabolic active lesion mainly in the left lower lobe parenchyma with infiltration into the left main bronchus.
Okay.
It was about 3 centimeters from the carina. Then there was a complete collapse of the rest of the left lung parenchyma.
Okay.
Mild to moderate left pleural effusion and enlarged left hilar and aortopulmonary window and subcarinal lymph nodes.
Okay.
There is no other evidence of any metastasis that was there. Only it was local spread in the lungs.
Now, with this, whatever it is, clinically we diagnose except that effusion.
Yes, sir.
I don't think anything that favors significant finding. Yes. Because difficult to make up. There is a volume loss, decreased burst sound, which can be explained by other reasons. Yes. If there is one hemithorax would have been more, means circumference wise, with the bulge intercostal, then you would have thought of there is a fluid. Yes. Otherwise, there is no clear-cut evidence to say. Agreed? So most of the features looks like collapse with the mass. Mass because there is a bronchial breathing with the evidence of some mediastinal involvement. Collapse because significant volume loss, mediastinum shifted to the same side, breath sound is significantly reduced. Agreed? Right? Yes. Okay, proceed.
Final diagnosis, we came across with metastatic squamous cell carcinoma of the left lung with complete collapse of the left lung.
Okay.
With mild to moderate pleural effusion.
Okay.
With diabetes, urinary tract infection, anemia. And,
so, do you think, can you tell the paraneoplastic manifestation in general of bronchogenic carcinoma?
Yes, sir. Paraneoplastic manifestations. One would be the hypercalcemia secondary to PTH-related peptide production, sir.
What you better say is hematological, endocrinal, neurological, musculoskeletal. Can you tell?
Yes, sir. Neurological.
First, start with musculoskeletal.
Musculoskeletal, it would be the SVC obstruction that would be.
No. SVC no. Paraneoplastic. Clubbing pulmonary osteoarthropathy.
Okay.
It's musculoskeletal. Okay. Hematological. Anemia.
Anemia, hypercalcemia.
Hypercalcemia is endocrine.
Okay, sir.
Migratory thrombophlebitis. Is right?
Yes,
possible. Sir. Endocrine.
Endocrine would be hypercalcemia.
Okay, then what other two important things they can have?
SADH can be.
Yes. One more. Cushing's.
Yes, sir.
Isn't it? What is the typical Cushing's in paraneoplastic versus other causes of Cushing? Do you know? Paraneoplastic Cushing
Yes.
versus weight gain Cushing syndrome, because they are too wasted.
Okay, sir.
You should suspect when any patient of malignancy lung with hypokalemic alkalosis. They will have the metabolic effect.
Okay.
The typical Cushing's feature is not there at all because they too rapidly deteriorate. Hypokalemic alkalosis, then yes, possibilities because of cortisol excess.
Yes.
Agreed, right? Yes.
Yes.
Neurological.
Lambert-Eaton myasthenic.
Start from above down, sir.
Or Horner's.
Sir, second year or final year?
Second year, sir.
No problem. Second year also should tell.
Yes, sir. Sir,
From above down.
Horner syndrome.
Horner syndrome is not paraneoplastic. It is due to direct effect.
Yes, sir.
Start from limbic encephalitis. Okay.
Okay.
Then
there can be cerebellar
degeneration, carcinomatous. Then
yes, sir.
Eaton-Lambert syndrome, peripheral neuropathy. Do you know peripheral neuropathy of paraneoplastic will have typical one antibody. I heard of this anti-Hu.
Anti-Hu.
And very typical paraneoplastic neuropathy, no? They can have bronchogenic. So you should say limbic encephalitis, bulbar involvement, cerebellar degeneration, Eaton-Lambert, peripheral neuropathy. These are the very typical parane. So hematological, musculoskeletal, okay?
Yes, sir.
Endocrine, neurological. They are typical.
Yes, sir.
Okay. Anyhow, this patient has got significant malignancy on the left, chronic smoker, along with that urinary tract infection, anemia, type 2 diabetes. Type 2 diabetes, I don't know, blood sugar was how much? I have no idea of this. Now I mentioned.
Sir, it was 340, sir, initially when he came.
Oh, blood sugar.
Yes, sir. Blood sugar was 340.
He's on just metformin, isn't it?
Yes, sir. He was only on metformin and.
Because he has got that recurrent urinary tract, no?
Yes,
So,
sir.
so maybe because of that uncontrolled significant diabetes mellitus.
Yes.
Okay, now proceed, sir. Right. Because your time is not much. Proceed. Next slide, sir.
So the treatment option for this.
Okay. I don't know whether it was given to him. I have no idea of this. Anyway, treatment option, you just put it, sir.
Yes, sir.
Given to him? This is,
no, it was not given, sir. It was not affordable. So, like,
okay.
Issue with
okay. Go to the previous slide, sir. Go to the previous slide. So, do you think you can explain all your symptoms, sign with that diagnosis?
Yes, sir.
Cough, sputum, breathlessness, hoarseness, weight loss, hemoptysis.
Yes, sir.
You can explain, I think. Cough, sputum because of pulmonary parenchymal, hoarseness may be laryngeal, we don't know, recurrent laryngeal nerve, hemoptysis because of the mass or intrabronchial, breathlessness because of significant volume loss of collapse, weight loss because of internal malignancy, maybe because of the chronic effect of smoking as such. It is possible. Yes, urinary tract infection.
Yes, sir.
What was the evidence? No evidence, no? There was no.
The culture report, it showed E. coli growth that was there, sir. I have not mentioned it here.
What type of urinary tract infection? Upper or lower it is? What do you think? With the way, how to differentiate upper versus lower?
Clinically, the upper will have usually a pyelonephritis, so there'll be high-grade fevers. There'll be a tenderness.
Pain in the back.
Pain in the back, renal angle tenderness. Frequency.
What is renal angle means, sir? What do you mean by that? Renal angle, where is it?
And at the junction of the T12 vertebra, sir, the lower end of the T12 vertebra and the spine.
It is from the last strip to the erector spinae. Yeah. The angle where the last strip and the erector spinae muscle, no, there is the renal angle. Tenderness there may be pyelonephritis, perinephric abscess, etc. So it may not be, we don't know, it may be a lower urinary tract. It is possible because in a diabetic with urinary tract infection, you should treat it as a complicated UTI. It is a part of the Same patient, sir, because patient should be treated in general everything.
Yes.
Anemia, hello?
Yes, sir.
Anemia is there, 9.1 type of anemia.
No, it was normocytic normochromic, sir.
So, what do you think anemia in malignancy?
Secondary to chronic anemia of chronic disease, secondary to the malignancy.
Yeah. What is the reason for that? Chronic disease causing anemia? Do you think anything you know?
So,
Because we say majority of chronic disorders
yes, sir.
produce anemia.
Yes, sir.
So, how they produce?
The chronic disorders, they cause chronic inflammation, and the chronic inflammation increases hepcidin, and they cause reduced absorption of iron from
absorption and utilization of the iron to the growing marrow.
Yes.
So this type 2 diabetes, it is totally uncontrolled, isn't it?
Yes, sir.
365.
Yes, sir.
Do you think that has contributed anything for this diagnosis?
That uncontrolled diabetes could have predisposed to the urinary tract infection and as well as the
lung disease. No, I don't think malignancy can occur. It is very unlikely. What to do for that diabetes mellitus?
Sir, better to start him on advise him for an insulin therapy,
because he has got evidence of such a major disease.
Yes,
isn't it?
Yes, sir.
Yeah. Okay, now another few minutes. Any questions from your side? Because 1 hour 20 minutes we discussed already.
Yes, sir.
Anybody or anything? Yeah. Any questions to be asked? You can ask, or any of your, I don't know, somebody listening or whatever it is.
Yes.
Sir, one of the member has asked how trepopnea is explained if there is no effusion.
Now, trepopnea is predominantly because significant left side parenchyma is involved. So whenever the patient lies down on the right side, no, because when a patient is disease on the left lung somehow cannot expand. So if he lies down on the left, the right lung can expand and the breathing is better. But if he lies down on the right side, the right lung also cannot expand because the left lung is totally diseased. You need not have effusion. You can have totally parenchyma not working also. That is the explanation for his trepopnea. Yeah. Any other?
One question is there.
Yeah.
Since the pathology was on the left, why did breathlessness worsen on lying on the left side, sir?
No, that is a history. What is not very relevant, I think.
Yes.
It is most probably the breathlessness the other way around should have been. Yes. Unless he has got a significant emphysema also on the right side. Yes. COPD with emphysema, no? Then yes. Anyway, he will be breathless. That is the reason, maybe because of that. So, in fact, in this patient, no, yes. When you percuss, you should look for hyperresonant note on the right. Because of that compensation. How do you differentiate COPD emphysema with versus compensatory emphysema? See, this patient can have both.
Yes, sir.
He's a smoker, he can have emphysema as such. Yes, or he can have a left lung disease, he can have a compensatory emphysema on the right side.
Yes, sir.
So how to differentiate compensatory versus COPD? Compensatory emphysema is unilateral.
Yes, sir.
COPD's emphysema is bilateral. Compensatory emphysema, breath sound is not reduced.
Yes.
In COPD, the breath sound is reduced. Compensatory emphysema, there is no wheeze or prolonged expiration because there is no bronchial obstruction. In fact, they can have a harsh vesicular breathing. Whereas COPD emphysema, evidence of airflow obstruction. So, they will have prolonged expiration, they will have rhonchi, reduced breath sound. So, compensatory emphysema, only hyperresonant note on one side, that's all. So, he may be having an additional COPD itself, which may be causing an additional breath sound on whatever side he lies. Okay? Right. Yes.
Yes. One more question is there, sir. You asked if you could tell us how to approach medicine in residency.
How to?
How to approach medicine in PG, sir.
Why? What happened? You are already in second year now. It is always better to do first year.
Yes, sir.
First 300 or 400 pages of that Harrison, no?
Yes, sir.
where the usual things are given.
Yes, sir.
And read monograms like cardiovascular, respiratory, gastrointestinal, CNS. One book for them and prepare a notes. Don't read those books again. It is not possible. So that all 4 major systems are covered. Whatever clinical cases keep, like valvular heart disease, congenital heart disease, read from a monogram, like big Brownard or congenital. Read stroke, degenerative disorders, neuropathy, muscle disorder from a CNS book. Prepare a notes. Read liver disorder from Sheila Sherlock or whatever book. Read respiratory, some clinical disorder from, there is so many books, Crofton, Douglas or whatever it is. Prepare them, make notes, and final year again start reading all those notes. Okay, so that the whole Harrison and Davidson is covered. One clinical book is covered. Basic high things are covered. So it is better. Some few 2 or 3 journals, New England Journal, Lancet, API Journal. 3 journals you have to be ready. Some basic aspect you should first year or second year you should finish. Like coronary, CNS circulation, CSF flow, okay, motor system, sensory. So first year is like this. Second year you can make that monograms and journals. Final year, all of Harrison Davidson. More important is to see the case and discuss. Theory part somehow you can make out.
Yes,
So better to have a discussion, present the case and get hammered.
yes.
Repeated hammering is advisable, sir. Hammering in the sense questioning,
Yes, sir.
by somebody, not hammered by somebody. Questioning by somebody, answering, commit mistake, get corrected.
Yes.
That's the best option.
Yes, sir.
Okay? Yeah. Right, sir.
Thank you so much, sir.
Thank you. Thank you.
Sir,
Thank you.
one more question here,
Yeah.
sir.
Yeah.
What are the signs, the upper respiratory tract signs to look for in respiratory system examination?
Yeah. First, look for deviated nasal septum, hypertrophy turbinates to rule out allergic rhinitis. Okay. So deviated nasal septum, hypertrophic turbinates, sinus tenderness, right? Maxillary, ethmoidal, frontal. Then look at the pharynx for pharyngeal congestion, tonsillar enlargement, tonsillitis, and including oral candidiasis, because majority of the upper respiratory will have steroid inhalers. Our COPD, asthma, they can have that candida. So you should be able to look for infection evidence, sinusitis evidence, allergic rhinitis evidence, and candida evidence whenever you examine an upper respiratory tract. Agreed, right? Yes.
Yes, sir.
Okay. Anything else?
Is it possible to have a mass without a mediastinal shift?
Yeah, it is possible unless what is called a fixed mediastinum. The mass is fixing the mediastinum, not allowing to shift infiltration, no? Then it may not shift. Yeah, fixed mediastinum is possible, not common.
Okay.
Mass is not allowing it to shift because it is fixing with infiltration. That is rare. Here the mass is pressing on the main bronchus, I think, where it is pulling on the left side, meanwhile conducting that bronchial sound, causing the collapse and bronchial breathing, both. Yeah, right.
Yes, sir.
Anything
What
else?
are the various mechanisms of breathlessness in a respiratory system? Is what they've asked, sir.
That depends on the disorders, no?
Yes. Cause of
If there is a massive consolidation of one lung with an underlying lung, then the breathlessness occurs. As such, emphysema, breathlessness, bronchospasm, breathlessness, diaphragm palsy, breathlessness. So it can be either upper tract with stridor.
Yes.
Anything above the larynx, breathlessness, difficulty breathing produces a stridor. Lower tract onwards, bronchial, tracheal pathology, bronchial pathology, parenchymal pathology, pleural pathology, mechanism of chest wall pathology, all can produce breathlessness. So that is how you have to approach. So it may be a bronchial pathology, asthma, bronchitis, all those. It may be parenchymal lung disease severe, ILD, consolidation, single lobe now, massive consolidation of both, or even ARDS type, possible. Pleural pathology, significant pleural pathology like pleural thickening, effusion, pneumothorax, unilateral, bilateral. It may be musculoskeletal pathology, ankylosing spondylitis, chest wall expansion is significantly reduced, possible. Or a diaphragm involvement, possible. Please rule out obstructive sleep apnea in all respiratory disorders presenting as chronic dyspnea. That's why I told the upper respiratory tract. Agreed, right? Yeah.
There is one more question, sir. How to identify different types of bronchial breath sounds?
Some experience required. Whatever it is, tracheal breathing mimics as though you are auscultating, tubular breathing mimics as though you are auscultating on the trachea.
Yes, sir.
So compared to that, compare here, the same sound will be heard. Agreed. Okay. Cavernous breathing will have some pitch difference. So there is high pitch. Cavernous is bit of a lower pitch. It is heard as though something like a lower sound. Emphoric will definitely have that metallic frequency. Okay. Some experience required. So you are blowing through a something like I don't know whether I am heard producing.
Yes, sir.
It is more of a tubular. It is more like a cavernous, hollow cavity like. It's a metallic sound. Okay, low pitch with the metallic component, more like amphoric. So some experience you can make out. So if you have got a doubt, put it on the trachea, put it on the same sound, it is tubular. Some hollow quality cavernous, some metallic tinge, amphoric. Like that you should be able to. Yeah, all right. Okay.
One more question. Important points to study in medicine during undergraduation.
Undergraduation. Who is it? The undergraduate is asking, is it?
Yes, sir. Undergraduate.
Basic aspects, Davidson, Hutchison.
Yes, sir.
Yeah. I don't say my book or whatever, don't worry. That also I don't say. Davidson and Hutchison is mandatory. Yeah.
I think your book has actually simplified all the other points from like many of the books which we read, huge books.
Yeah, I have released recently postgraduate edition I have released.
Oh, okay. Sir.
Yeah. Clinical, 1 week back it is released, clinical medicine for postgraduates. It's available in the same CBS. Yes, yeah.
Thank you, sir.
Thank you.
They've asked what is the mechanism behind, I think, bronchial breath sounds they've asked, sir. Why metallic tinge and why?
No, bronchial breathing as such,
Yes,
whenever it is solid is a good conductor of sound. I don't know whether you remember that.
Yes, sir. Yes, sir.
In a patient of consolidation, etc., there is no filtering of that tracheal or bronchial sound. It directly conducted to the chest wall. So that is the reason the same sound is heard. Cavity is like a hollow space, almost the same sound with the hollowing. Metallic is because of that air vibration. That a detailed thing may not be required. They may not ask, but if you say there is no significant filtering of the tracheal or bronchial sound, which is conducted to the chest wall, you can say. Yeah, right.
I think questions, it was very...
Okay. Anything else, sir? No.
Thank you so much, sir, for...
Thank you.
Thank you.
Thank you,
sir.
It was indeed a comprehensive clinical class. The discussion was very useful for us. Thank you so much, Professor B. Shastry, sir, for teaching and guiding us. We are ever grateful to you.
Thank you.
I need your blessing, guidance, and support throughout, sir. It was a great effort by the presenter, Dr. Vijay Balaji, sir. We could learn a lot because of your well-prepared presentation. We also thank all the participants who were enthusiastically
Definitely. He did well. Vijay Balaji did well. Yeah. Hello?
Yes, sir.
Yes, sir.
Yeah, he did well. He was answering well. Yeah. Yes, prepared a lot, I think. Anyhow. Okay. Thank you.
Thank you,
Thank you so much.